and one destiny. And of course, most Jamaicans now will greet you as one love, one heart, and one destiny. It really is a pleasure for us to have this conference. It really feels fantastic. We're learning every year as we go. And of course, one of the things we Jamaicans have difficulty about is the start time, you know. So I used to be a stage manager of a play in Jamaica, which we titled 8 o'clock Jamaica time, and we'd start at 8:30. So it really is a pleasure to have you here, that you have braved the Easter weekend to come out at this time. And who is we? We are the Caribbean Institute of Mental Health and Substance Abuse of the University of the West Indies. This is a center that was set up in 2006. And as I was telling the president of the American Psychiatric Association, Dr. Arthur Stewart, last night, CARIMENSA, as it's called, as we call ourselves, is, as far as I know, the only primary prevention mental health organization in the world. I checked this out because I asked my friend Lawrence Carmire in Montreal, who is the chief transcultural person, one of the chief transcultural person, to put it out on his listserv, and he did. And we got back one response from England, and they really didn't have, they had something that was going towards that. But it really wasn't a primary prevention institute. We take the view that we have to solve the problem before it starts. And so our organization is not into treatment. We don't treat people with problems. We try to prevent the problems before we start. And so we do service projects, we do training projects, we do research projects, we do teaching projects. And that's the nature of the Caribbean Institute of Mental Health and Substance Abuse. And as the morning and the weekend goes on, you will meet the local people who have been really involved in this over the last few years. I really have to say something about the University of the West Indies and the vision of somebody like the principal, Professor Archibald MacDonald, who was really one of the people who have been supportive of CARIMENSA. He wrote to me this morning to say that unfortunately he'll not be able to come to give greetings, but he has asked Dr. Robertson Hickling, who is a senior lecturer at the university, to bring his greetings on his behalf. So I really want to thank the university, and for those of us who are learning how to do this thing, we really have to understand that you have to have an institutional base to support you when you're doing this kind of stuff. Very important. Then I really want to say thanks to the McGill Global Mental Health Foundation, because there have been two people who have been really instrumental in helping us on our way in this. One is Professor Jaswant Guzda, who is an eminent child psychiatrist. She's over here. You will hear from her later in the day. She's not only a child psychiatrist, but she's a fantastic fine artist. And she has had exhibitions all over the world of her artistic endeavors, not only about her mental health stuff. So she has been one of the people who has helped to trigger this particular work. The other person who now passed away is Professor Duncan Pedersen. And so I really have to make a special commentary about Duncan Pedersen, also from McGill, and he has helped us to chart the global mental health direction for the future. And we are really saying we want to chart this future for the whole world. We are especially interested in the Caribbean and in Africa. Last week, I was in Malawi speaking at the training program for 48 new mental health workers across South Africa, Malawi, Zimbabwe, and Ethiopia. And so we, CARIMENSA, are involved in the African revolution, in the mental health revolution in Africa. So I then would like to really thank our presenters, because we have a wide raft of presenters, both international and national. The international ones, you will see them in your program, but they are here with us. Of course, Dr. Arthur Stewart, I mentioned her before, is the president of the American Psychiatric Association, the first black woman, the first black president of the American Psychiatric Association. Then we also have the daughter of our patron, Frantz Fanon, and her name is Mireille Fanon Mendes France. And she has come here from Paris, but she's really a Martinican, Caribbean, and we will be hearing from her tomorrow. The third person is Professor Amy Charles Nicholas, and he's the professor of psychiatry in Martinique, our Francophone colony here in the Caribbean, and that's Amy Charles Nicholas. Up in that top right-hand corner is Professor Ben Bowser, and he is a professor of sociology. So in other words, we're looking at the whole spectrum. He's over there on the right. He's from San Francisco. Welcome. There's one other person who is Ann Bailey, who is a professor of history. She's here in Jamaica, but not here with us till tomorrow. The local people are equally eminent. First of all, you're going to hear from this morning is Professor Maureen Sams-Vaughan, who is a professor of pediatric psychiatry in this country. Maureen, right here, she's one of our stalwarts in this process, and certainly an old friend and colleague of mine. We'll also be hearing from Dr. Deborah Chambers, who is on the right, who is a PhD in clinical psychology, and she has been fantastic for us. Debbie over there. Beside her is Dr. Jeffrey Walcott, who is my right arm, not this one, right arm. And he will be speaking to us as well, but he helps me to run CARIMENSA. So welcome, Jeffrey. And of course, there are others who are not here, Dr. Christopher Charles, Dr. Herbert Gale, who will be speaking tomorrow. And I really want to mention, finally, my wife and other three-quarter, and that's Hillary Robertson Hickling, who will be speaking to you later on today, and who the principal has asked to read his welcoming greetings. Finally, I would like to say that one of the people who we had hoped to come was the professor of psychiatry from the University of Zimbabwe. His name is Dixon Shibani. He's a fabulous man, and he has done some phenomenal, groundbreaking international work on a system called the Friendship Bench, in which he has introduced the Friendship Bench all over Zimbabwe. So people who don't have access to mental health services can have a place where they can sit down with counselors and share their problems. Person I'd like to welcome who has just walked in is our Professor of Psychiatry, Dr. Roger Gibson, Professor Roger Gibson, who will be sharing the platforms with us this weekend. Welcome, Roger. So we haven't been able to get Dixon in the flesh, but I hope the technology will allow us to bring him in by Zoom, is it? And we'll be able to actually see his presentation. I think that's enough from me. I want to thank you all for coming out. It's certainly wonderful to see you. And hey, I'm very excited to see how the weekend is going to progress. Dr. Robertson Hickling.
Good morning, everyone. Of course, you can see that I'm not Professor Archibald MacDonald. But I would like to deliver his brief remarks. A pleasant good morning, ladies and gentlemen. As principal of the University of the West Indies, it is my esteemed pleasure to welcome you to the 2018 staging of CARIMENSA's Conference on Mental Health. This year's conference is an especially poignant one as it brings to the fore the often under-researched interconnection between mental illness and violence in the Caribbean. From trauma-related illnesses such as PTSD to the side effects of depression and suicide created by the impact of witnessing some form of violence. The health and stability of our society has been under attack for decades. With Jamaica's high crime and poverty rates, the pressures placed on the everyday man and woman continue to function in a somewhat difficult society, despite their emotional and psychological ability to do so, have resulted in many of our young Jamaican men and women suffering in silence from illnesses that are easily treated with modern-day medicine. All too often, we hear of family members, friends, colleagues, the young and the elderly experiencing psychological breaks because of the societal factors such as ongoing violence and poverty. Have had on their ability to cope. This is indeed a situation that is untenable and one which deserves greater recognition and attention from our entire society. I'm therefore encouraged to deliver greetings to this very important conference as it represents a crucial step to bringing violence-related mental illness and its sufferers to light, providing them with a platform to speak of their illness and educate our society. I'm also pleased that this conference aims to explore the work, contributions, and achievements of one of the Caribbean's foremost psychiatrists and philosophers, Frantz Fanon. His work has had undeniable impact on how we approach psychological treatment in our region and has paved the way for others in the development of this field in medicine. As a learning institution, this is our primary mandate: to educate and stimulate discussion on issues that are often swept under the public's rug. It is in this vein that I must commend Professor Hickling and his team at CARIMENSA for being the frontrunners in addressing mental health in our society. CARIMENSA's outstanding and commendable work is helping to create a positive shift in the paradigm in this sector. And I'm pleased that they have facilitated this conference to further engage the public and various stakeholders on the possibilities of improving mental health in Jamaica and the wider global society. Allow me to take this opportunity to formally thank CARIMENSA for staging this conference and to also extend our appreciation to McGill University for supporting the development of a better mental health sector in Jamaica through research and education. It is my pleasure to extend a warm welcome to you all. to what will certainly be a lively and informative day of discussion and presentations. Thank you all for joining us and do enjoy the conference. Let me add my own personal welcome to Stephen Hennessy, who has come from Montreal, who has worked with Professor Guzda and works in the African Caribbean community in Montreal, dealing with some of the very same issues which we're dealing with here. Welcome, Stephen. Am I now to be followed by, because I see the representative of the Ministry of Health. I'm not here. This is what you call teamwork, folks.
That's why she's my right hand, you know. And more than my right hand, she's my better three-quarter. So we'd like to welcome now to the podium the representative from the Ministry of Health to bring greetings from the Ministry of Health, and she's Dr. Melody Ennis, who will speak to you at this moment.
Good morning, ladies and gentlemen. Let me first apologize for the Honorable Minister of Health, Dr. Christopher Tufton, who is unavoidably absent this morning. However, the importance of this conference did not go unnoticed by the Minister himself and the Ministry of Health, and as such, he has asked that you take hold and heed of his message, which I shall read for you. The Minister wishes to commend the Caribbean Institute of Mental Health and Substance Abuse, CARIMENSA, on staging this third annual Global Health Conference under the theme Mental Illness, Violence, and the Delusion of Freedom, Exploring the Legacy of Frantz Fanon. I'm particularly pleased that our local team could be joined by Dr. Stewart, the president of the American Psychiatric Association, experts from Canada, Latin America, the Caribbean, Europe, and Africa, underscoring the response that has to be comprehensive and multi-sectorial in order to ensure a coordinated service which includes prevention, treatment, rehabilitation, and protection and care recovery. The hosting of this national conference is indeed a huge accomplishment, and I want to recognize CARIMENSA for leading this charge. Excellent work, Professor, for your stewardship, and of course, the entire team. But not only for this conference, but more importantly, for reshaping and repositioning mental health here in Jamaica and indeed the rest of the world. Mental health has remained an important part of our health agenda. We have long boasted a national mental health program here in Jamaica, but despite the many gains, we have had some challenges, and we are merely but scratching the surface of this very challenging and multifaceted health issue. Jamaica is plagued by very high rates of violence, giving rise to many children and adults with post-traumatic stress disorder, depression, anxiety, and the list goes on. This conference is therefore timely in its attempt to delve into the socio-political consequences of transgenerational trauma in our culture. The information garnered and the partnerships being cemented here will no doubt advance the holistic approach to mental health care. Persons with mental health conditions around the world are deprived of their human rights. Stigma, social exclusion and discrimination, as well as physical and emotional abuse are significant issues that affect them on a daily basis and negatively impact interventions put in place for corrective action. Jamaica is by no means an exception to this, and we must continue to empower our people to break away from this practice, continue to educate them in how they can assist persons affected by mental illness. The Ministry of Health has implemented several measures to improve the mental health services here in country. In 2016, for example, we started a task force on mental health and homelessness. This was certainly to improve services through the promotion and development of a community mental health program, addressing the needs of the homeless and improving social services for the aging population. Additionally, Jamaica is a signatory to the Convention on the Rights of Persons with Disabilities, and in keeping with this, a draft workplace mental health policy has been developed. But while legislation and policies, guidelines are important, they are not sufficient to accomplish the changes that are necessary and in the time frame that they should be accomplished. We have also taken some important steps to improve mental health access and quality of care with the integration of mental health into the community health program. Training of mental health officers, psychiatrists, mental health nurses, psychiatric aid is all ongoing, and resources are being pumped into primary care to enhance this program. With the technical cooperation from the Pan American Health Organization and the World Health Organization, we have been implementing the Mental Health Gap Action Program, which seeks to integrate mental health care, as said before, into primary health care. Mental health is inextricably connected to physical health, and we have also launched a Jamaica Moves campaign, which aims to encourage all Jamaicans to practice a healthier lifestyle, starting with physical activity. The government of Jamaica is committed to providing for our citizenry the holistic health care that they deserve. It is opportune for this conference today to focus on mental health care and services. We want to thank CARIMENSA for making this possible and for continuing to do such a grand work. Thank you and welcome all. Have a wonderful conference.
Wow. I really would like to thank the Minister of Health, Dr. Christopherson, and the principal, Professor Archibald MacDonald, for their support of this conference. I really want to say, as far as that's concerned, when Dr. Ennis was articulating the governmental support for this, this has been going on for 45, maybe 50 years. And I think that we in Jamaica have one of the most advanced mental health systems in the world. I've been all over the world and I've seen and worked in all of these systems. We are way ahead of the world. We may not know it, but this is the reality of what happened here. And I can tell you it's not happened easily, that we have had tremendous struggle with the population, with the organizations, with the governments. But hey, it looks like everybody's on board now, and more so as the needs become clearer to the population. So I really want to move into the meat of the discussions of this conference by inviting the next speaker up, just to say a few words about her. Arthur Stewart is a remarkable woman. I've known her since 1978. Or 79, thereabouts. Sorry about that, Arthur, but it's just the truth, you know. The truth has to come forth. When she came here as a resident, a third-year resident, to a psychiatric conference that we had on the North Coast. And we have had a fantastic friendship ever since. And I've watched her move through the highways and the byways of the psychiatric system in the United States of America, which is no easy task, I can tell you. The mental health system in the United States is a forest. It's really like a maze to be able to understand how it operates. And it really in my view, doesn't deliver the mental health service to its people, as I think we are now beginning to recognize as the present-day American situation plays itself out. So it is really with these comments of introduction about the new president of the American Psychiatric Association, who is the first black president of this 174-year-old organization. And she's not only the first black president, she's the first black woman president of this organization. The American Psychiatric Association, I think, has about 35 to 40,000 members. There are psychiatrists all over the country. I claim it because I've been a member of the APA since 1977, and in fact, I've been honored by that association as being a Distinguished Life Fellow of the American Association. So it is both as a Jamaican psychiatrist and as a Life Fellow of the APA that I'm really welcoming my friend and real friend, who is the president of the APA, Dr. Arthur Stewart, to speak with you.
Still knows how to embarrass me. You would think after all these years, he would have forgotten or I would have gotten used to it. Unfortunately, neither has occurred. Good morning, everyone. I'll just let you do your thing. Okay? Everyone here? Yeah, I think we're on again. Well, I am truly honored to have been invited. Thank you, Dr. Hickling, for the invitation. And let me add my welcome to all of you for coming out on this wonderful, beautiful Jamaican Saturday morning of the Easter weekend to hear and discuss with us some of these challenges that we all face and acknowledge. I would be remiss in my duties as president-elect. I actually take office in May in about 6 weeks, but Freddie won't say elect, so I just go with it. You don't argue with him, as you know. The actual membership number recorded as of 2 weeks ago was 37,890 members. The largest psychiatric organization in the world, and the oldest in the United States. And so it is a tremendous honor for me to have been elected to the position. And I will tell you a quick story. The last time I saw Fred, we were in South Africa for the African Diaspora Conference. It was during the presidential campaign that I was running. And he pulls me aside. I think you were there too, Hillary, when he did this. He pulls me aside and says, "You must win." I said, "Okay." No, you must win. You have to win. And I said, okay, I'm doing my best. You know, I'm campaigning. I'm here on the international stage with my the candidate who was opposing me. I'm doing my best. He said, no, you must win. And as things happen the way he says they will, I won. And I'm really pleased because you predicted it and said why I had to do it, and here we are today. This invitation represents a real coming full circle. He started the story of the trip in '78. There was a group, the Black Psychiatrists of America, which is about to celebrate its 50th anniversary next year. And it was my first international meeting, my first trip to a psychiatric conference that was staged by Black people, and that represented an international audience. And I really grew up professionally within that organization, and that set me on the path to where I am today standing before you. And so I'm particularly honored to have come back to Jamaica for this celebration of the work that is being done here. I will also blame Fred for the fact that up until about midnight last night, I had a perfectly planned talk, and that comment that he just told you that he made about having the only mental health prevention in mental health program triggered some thoughts in my mind that wouldn't allow me to sleep until I made a few tweaks. So the talk I'm presenting at the beginning today is different from the one that I arrived with last night. I just tell you that by way of understanding the impact that someone like Dr. Hickling can have on you just in a brief interaction. I'm going to talk today about the worldwide challenges of complex trauma and children's mental health. And I do this by way of bringing greetings from the American Psychiatric Association, from the Black Psychiatrists of America, who just had their spring conference and talked about some of these same things just a week ago, today actually, and my home university, University of Tennessee Health Science Center in Memphis, Tennessee, where I'm on the faculty and I direct the Center for Health and Justice-Involved Youth. Trauma, children, violence, disrupted lives, and challenges to the field are all part of my daily work now. And so everything I will tell you today reflects a part of what I do and why I do it and what I think we can do better and differently and need to do together. In the United States, this has become the topic of adverse childhood experiences. I'm sure most of you have heard of ACEs, and the original work around ACEs was a study conducted at a private insurance health plan on employed, basically healthy, mostly white, middle-class individuals that gave tremendous opening to having this discussion that we are having today, because the people who conducted the study were surprised with the outcome of the study. That here these very healthy, middle-class, mostly white, employed individuals had these health issues that appeared to connect to experiences from their childhood that could be connected by these researchers. They were amazed. They had expected this might happen in an impoverished population. They'd expected this might happen in a third world country, in a developing nation, but not in middle America. Kaiser Permanente, one of our biggest health plans covering millions of lives, they really didn't expect to see that. And that work led to a lot of other things happening in the US and finally hitting the international stage. Recognizing that worldwide children are exposed to many, many horrific kinds of things, whether it's war, natural disaster, but also these other traumas, violence in their home and their community, abuse, emotional, physical, sexual, all variations on trauma, from bullying at school to sibling bullying in the house, and all those things, and that those things happen irrespective of your geography. There are pieces of those things that happen in every nation, in every culture, amongst every socioeconomic status. And that you can demonstrate that these adverse childhood experiences can and do affect your lifelong health experience and the development of a myriad of psychological and medical problems. And it traces back to that original study where they made these connections and now are making these same connections on the international stage. As I said, it happens in developing and developed nations. It contributes to a host of things, including organized violence, criminality, forced marriages, witnessing criminal behavior, and collective violence in the community, and the other things that I've mentioned. The area now where this is finally penetrating is the whole discussion around global burden of disease. We all know things get triggered at the global level when groups like the World Health Organization, the World Bank, and others decide that these are things that will impact significantly populations where cost and public health impact will be great, and that drives their interest in these things. But it's interesting to note that even childhood sexual abuse was not entered into the global burden of disease discussion until 2014. That's not supposed to be 2000. See, Freddie, this is your fault. That's a typo thanks to the tweaking. That should be 2014. That only a few years ago, that began to get factored into the discussion around global burden of disease and what it was costing in health days of living and in cost to each respective area where these things were occurring. In part, the largest burden from ACEs is from the cumulative effect. It is not a single assault on the child's psyche and neurocognitive functioning. It is that cumulative effect of the chronic exposure to a host of adversities where there are lifelong consequences that only become apparent after many, many years of exposure to these things. And now that this work is moving from the primary focus in the United States to the global stage, now we have to go back now and define what exactly are we talking about. How do we define global burden of disease and health when we talk about ACEs? Because that's what we're going to need to do to build this framework to understand how we go about surveilling this from a public health standpoint, and more importantly, how we look to prevent the problems that come about as a result of these experiences. And that's the prevention piece that I think is going to become more and more important as we move forward. These kinds of stressful, traumatic childhood experiences become a common pathway to the kinds of impairments that we see in children who grow up to be adults who've been impacted by these adverse childhood experiences that are all at the base of healthy, unhealthy behaviors, risky behaviors, disease, disability, and ultimately premature death. This disruption in the neurodevelopmental channels for children have lasting effects on their brains and function, and probably cause some of the findings that we see every time this ACE study gets replicated in different areas. There are actual changes in the brain as a result of trauma. We can tell this through scientific research. We have studied this, or some have studied this in various populations, in different geographical locations, and now in an international study that has been underway. This is why it is so important that we shift our thinking from this is a mental illness and requires a treatment to shifting to this is a public health issue that requires an approach of prevention. We will never get out ahead of this if we don't start looking at prevention. Here in Jamaica, CARIMENSA is looking at the prevention portion of this. In the work that I do on a regular basis, we have missed those kids when they were from birth to 3 to 5. I'm getting those kids because in school they're being suspended, expelled, there are behavioral problems, families are disrupted because of child welfare involvement because of this behavior, and these kids are on the fast track into the justice system from which many of them will never be extricated if we don't do something. So we're still at the intervention mitigation phase in my program. We haven't been able to leap into the prevention, but that's where we hope to get and get upstream of this problem. The public health approach gives us a couple of opportunities. There's some short-term things that we can do around ACEs to address those behavioral health and physical challenges, but also to take a look at what consequences, if we don't do the prevention, will occur and begin looking at ways to mitigate and intervene early if we have missed them on the prevention side. This is just a little timeline that I put together to give you a sense of globally how the world is now looking at adverse childhood experiences, childhood trauma, children's exposure to violence. It goes by many names depending on where you are, but it is essentially all the same thing. Something horrible, horrific, tragic, terrible happens in the life of a child. That child changes, brain changes, physical changes occur, and over time, the continued assault of these kinds of things is reflected in their overall health status. That's basically what we're talking about. So the World Health Organization produced a report on violence and health in 2002. A few years later, a study was conducted by the UN on violence against children. A few years after that, the World Health Organization and some other groups had the bright idea to create an international ACEs research network to advance global understanding and measurement of these adverse childhood experiences. And as a result of that network, began field testing in 7 countries, and you see them listed here. Interestingly enough, nowhere in the Caribbean was this looked into as part of the original field test. And at the end of that field testing, They produced another report, which is available online. The ACE IQ is the Adverse Childhood Experiences International Questionnaire, which is the tool, the survey instrument that is used to collect the data that was provided from the field testing. And so there is a report online available for anyone who would like to see it. It's kind of interesting because in many respects, if you look at the original ACEs that was done in the late 70s in the United States and look at the results of the field test with some cultural adaptations given where people are and what other things are happening in their nation, you see very similar results. Adults, because this is all an adult questionnaire reflecting back on childhood experiences. These are not things that we ask children about. These are adults being questioned about experiences that they had before the age of 18. And you see reflected in the international responses the same general themes. 3 domains: abuse, neglect, and things in your household that were different enough that they impacted you. The abuse can be sexual, physical, emotional. The neglect can be everything from didn't have enough to eat, someone always told you that you were no good or not worth anything, you were bullied, or you witnessed people who had violent acts committed against them. And in that sort of things that happen in your household that have an impact on you, the questions revolve around anyone in the house with mental illness, anyone in the house been incarcerated, at any point was there instability in the household by divorce or being homeless and things like that. And so these 3 domains across the board gave consistent answers no matter which population was being tested, which begins to validate the notion that there is something going on in the childhood experience that gets reflected in the adults' recall of that experience and in their health as a result of that experience. And then when the focus at the UN and the World Health Organization moved away from communicable diseases because we had done such a wonderful job, thank you. We had done such a wonderful job of managing them and had, done malaria and polio and all of those. And it began to shift to non-communicable diseases. It became clear that ACEs, childhood trauma, exposure to violence, was going to be right up there at the top of the list of things that we needed to take a closer look at and study more deeply. And so the UN convened a summit, and some of the work that has come out of there will be available to you online. You can check that out. So at the time that this is happening on the world stage, things are also happening for me and for Americans in the United States. We have a couple of seminal events. We had a black Surgeon General, Dr. David Satcher, who issues the first ever Surgeon General's report on mental health. It is followed by a report on culture, race, and ethnicity in mental health, a report on children's mental health, and a report on violence in the community. And all of these together create this sort of groundswell of attention to these issues in the lives of many people, A, who rely on the public sector and publicly funded services for their treatments, but also who, B, rely on the public, the general public, government, and all of that, for ideas around public health approaches to providing the services that they need. And so I lifted this out of his book to show you the significance that Dr. Satcher gave to mental health overall in the context of good health for everyone. And then in the U.S., of course, we pride ourselves on being, I think you called us, we think we're the center of the universe. And in many respects we do, but we pride ourselves on taking into account things that happen outside that might be helpful to us remaining the center of the universe. And so we've adopted the notion of social determinants of health being important in the context of understanding what constitutes good health. And they have the phrase, the conditions in which people are born, grow, live, work, and age, which we have modified somewhat in my part of the country, but that there are investments that you make that are reflected in improved health status is the bottom line. And when those investments are not made, you get disparities, inequity, poor health outcomes, and the kinds of changes that we are seeing happening in children and their mental health in the United States, and overall in the health status of many Americans who don't have access to good health care. There was a commission on the social determinants of health established by the World Health Organization, which came up with the social injustice killing people on a grand scale, which really concretizes the notion that what we aren't doing for health really is killing people, and the reasons that we are not doing it have more to do, as much to do with social injustice as they have to do with poor access, limited workforce, and other things. That there is an injustice built into the U.S. healthcare system, and perhaps into the global healthcare system, and that's part of what I think we'll be talking about here this weekend, that is killing people, literally killing people, and that is unacceptable. I think I skipped one. This is the Surgeon General's report on mental health, which included an agenda of action. Why we have to do something. I'm going to shift a little bit and talk specifically about my work and my experience and how I come to this understanding of what we need to do, and hopefully offer up some challenges and opportunities for this audience over the next couple of days. This is a slide that tells the story of my day-to-day life. I work, as I said, in the juvenile justice system. Up to 70% of those kids have at least one diagnosable but untreated mental health disorder. 70% have experienced at least a single traumatic event. 30% have some kind of diagnosed learning disability. 48% function below their academic grade level. So this is as at-risk a population as you can get. And they're already being channeled into the criminal justice system as opposed to being offered some service or support for what is clearly an issue that could be dealt with through services and support. So this is the context for how we come to do the work that I do on a daily basis. I love quoting my early prevention expert, Frederick Douglass, who tells us early on that it's easier to build strong children than to repair broken men. And there is something in that is important for us to all remember. The work that we do to support good mental health in children creates strong adults. If we don't do that work, we don't get strong adults who are thriving, productive, contributing to their communities. This is early prevention, and Frederick Douglass is not known as a public health proponent, but he clearly makes a strong statement there. As it relates to childhood trauma, there's a program in Tennessee, a statewide program. We happen to, for those who follow the politics of the United States, I live in a red state, which means it's very strongly Republican, very conservative fiscally, does not like anybody telling them what to do. We want to carry our guns. We want to do all these other things. We don't like that. I should say most Tennesseans don't like that. And so to have a governor and first lady of the state who decided that they would invest precious resources that they have at their disposal into a statewide initiative to deal with this issue from birth to 5 was a tremendous bit of progress, we thought. And so our governor has created a 3-year funded effort, over $2 million a year for 3 years, with a primary focus on early childhood, 0 to 3. And it encourages prevention, but recognizing that we've missed the boat on so many of the children who are trapped in the systems, whether it's child welfare, residential programs, or the juvenile justice system, recognizing that we've missed the boat for many of them. They also funded intervention and mitigation strategy programs, of which mine was one. And when we got, it's called Building Strong Brains. That's the formal name of this statewide program. And there's a whole history behind that I won't bore you with that has to do with messaging and framing a strong brain as a sturdy house that is built with particular kinds of expertise, and anything that's missing in the foundation of the house creates a problem in how the house stands. But its goal was very simply what's here, increasing the potential that every child born in Tennessee could actually get a shot, an opportunity at leading a healthy, productive life, raising public awareness about adverse childhood experiences and their overall impact, not only on the child today, but on the health of that adult when the child grew up in the future. And of course, all of this in a political sense is wrapped in the fiscally conservative, we can pay now or pay later, but we really shouldn't pay at all since the science tells us we can do things differently. And that's part of working in sort of the government sphere. You learn to figure out how to get what you need done by understanding where they want to get. And economic bottom line is what every fiscal conservative wants to see. Having the chance to impact public policy in our state to support prevention overall down the road at some point, by reducing the conditions at the community level, at the individual home level that were contributing to these things, so that there were a myriad of opportunities for each program that got funded to propose things that would really get to the heart of where is this happening in the community, why is it happening, what's missing, what do we need to add, who do we need to work with, what kind of training, education, outreach do we need to do, and looking for ways to encourage this to continue. And before I left town yesterday, we got word that there was another budget request put in by the governor, even though he's leaving office this year at the end of the year. He's put into the next budget cycle another 3 years of funding. And unless his successor decides to incur the wrath of a lot of influential people in the community, including some very active church people, we suspect that we're going to continue to get that funding. But it gives us a chance to take a fresh look at this stuff, to look at the science, to figure out what the population that we're working with needs, what they will respond to, how they come out to get these kinds of services and supports, and really look for ways to precisely measure outcomes, improvements, and all of those things that get you on the road to becoming at least evidence-informed on the way to becoming evidence-based, because everything in the United States is based on evidence. And you can get tons of funding if you've got an evidence-based practice. You get very little if it's, well, it's worked on this group and we think it'll work, but we're not sure because we don't have any data. The seeking of sustainable funding becomes critical in these kinds of situations, because I can count on one more budget cycle perhaps, but after that I can't count on government doing the right thing. And so along the way, we've got to figure out creative ways to encourage other means of support for programs that we know are working. And that's part of now my day-to-day existence. So what does this look like? I'm in the Department of Psychiatry. That's where my faculty appointment is. And so I have my program, which we call PCAT, Protecting Children from ACEs and Other Trauma, which works with kids who are chronically truant and kids who are on the path and we want to divert away from the juvenile justice system. We also have at the university, through our Center for, what is it called? The Bowling Center for Learning Disabilities. We have a host of trained therapists who do a variety of things, mostly TFCBT, trauma-focused cognitive behavioral therapy, but who actually provide this service, this structured, evidence-based service, which we can monitor, manage, and measure for kids who come through our program and need a specialized kind of treatment to deal with whatever the trauma assault has been. And through the Department of Pediatrics at the university, we have a combined collaborative program with our Department of Pediatrics, where our child psychiatry fellows actually provide on-site consultation to the asthma and obesity clinics that are outpatient clinics that are run through the department as a first step. These are things that have been in place now for a couple of years, so we're still hopeful that we can get the kind of data that will demonstrate their effectiveness and allow them to continue to be supported through the next wave of funding at least, and then after that we hope to have been able to demonstrate to the insurers that cover most of the kids in this clinic that this is a needed additive service that they should continue to cover once the state funding is lost. an example of how this actually works, I look at things from the intervention, information sharing, and policy development standpoint. As a standalone center within the university, my existence, my continued existence depends on if I've got something that I think works and I can demonstrate its effectiveness, if I can tell people about how it works and why they should be supportive of it, and if I can use all of that information to get a policymaker, a funder, or someone in the echelon of government that makes the final decision on what does and does not get done, whether it's funding or implementation. That's my three-legged stool. And so when I think about my work in the adverse childhood experiences, I think about Memphis as a predominantly African-American community. I think about the way we engage people in Memphis is twofold. General community things happen through the usual, community meetings, school things, health fairs, and those kinds of things. But we are what is called in the States the Bible. We're in the Bible Belt. In fact, Memphis is known as the buckle of the Bible Belt. And so a reliance on the faith community, however that is perceived, becomes critical with introducing new ideas into this community. And there's a big, strong movement of the Black church and Black churches in Memphis that actually have have embraced the concept of childhood trauma leaves lifelong effects, and are really working very hard with us to push this message out into the broader community beyond their respective churches. And so that is part of our community engagement process, and we have a full evaluation component now that is actually looking at evaluating the effectiveness of our programs and our messaging to the community about that effectiveness, and our reporting to the funder about that effectiveness, to assure that we are accountable to the people who fund this and that we have